The pleasure and the honor is all mine, Dr. Ashrafiad, and it's true. We have been friends for a long time and many times have discussed whether or not we were separated at birth or perhaps sisters from different mothers. At any rate, having said that, I have many close friends and extended family with Dora and her family in Greece, and I understand that you practice radiology at the absolute highest level. And so I am honored to give this presentation on MSK overuse injuries in the pediatric population. If you'll bear with me just for a moment while I share my screen and start my talk. So I have no financial disclosures related to this presentation. The objectives of our time together today will be to describe commonly encountered overuse injuries in the pediatric patient and to review relevant anatomy. I'll show you sentinel cases in the wrist, the elbow, the shoulder, the hip and the knee, and we'll emphasize a few important points. Structural vulnerability as a consideration for patterns of failure, comparing and contrasting pediatric versus adult injury, really to understand the mechanism-driven nature of overuse injuries, and to review differential considerations of the imaging findings when applicable. So as we consider the major structural vulnerability in the pediatric versus the adult skeleton, clearly we're dealing with the physis and physeal equivalents, showing you a histologic preparation of the epiphysis. Here an MR image, not fat suppressed, showing the epiphysis as well as the apophysis considered an epiphyseal equivalent. As we consider mechanisms for overuse, here the hip, of course, a lower extremity, and load-bearing articulation, we know that we load the epiphysis through weight-bearing, jumping, running, and such activities. On the contrary, however, as we consider the apophysis, the epiphyseal equivalent that I mentioned to you, this is often the site of soft tissue attachments, and through contraction of muscle, we'll have tensile forces which pull on those apophyses. So as we consider mechanism and the mechanism of injury, we'll consider how that affects these areas of gross structural difference. When we consider the risk factors for overuse injuries in the pediatric population, clearly prior injury is something that we take into consideration. While we like to have gross rules of thumb or standards when things will happen with respect to growth spurts or growth cessation, we realize that every patient comes to us as an individual with great degrees of variability. We have to consider the timing of that adolescent growth spurt. In the United States and globally, there has become a trend for year-round participation in a single sport with early specialization. 15 to 20 years ago, kids would play different sports in a seasonal nature, perhaps soccer or football, as you would call that in one season, perhaps different sports as you move through the year. But now, again, this early specialization where the children are playing the exact same sport all year long and with very intense training regimens really plays into this idea of overuse. The increased volume and intensity of training, of course, as we know, and considered with those tissues that are vulnerable, physis and apophysis. A few examples shown here of the sequelae of these injuries. With a chronically open physis, we could see asymmetric closure and abnormal morphology of the bone over time. Bone bars can lead to something similar like that with a physeal injury, as well as the structural changes you see here with the classic fishtail deformity in the distal humerus. I've lectured a few times to the Society of Pediatric Radiology in the United States, and as an adult imager, they've often cautioned me, now Christine, please don't show us osteoarthritis or degenerative change because we are pediatric radiologists. Well, of course, I feel compelled to start with these sets of images on the plain film. The classic findings of degeneration, although somewhat subtle, osteophyte formation, subchondral remodeling. As you look at the MR in this patient, areas of full thickness chondral loss, reactive marrow changes, perhaps even cyst formation and labral tearing. Why do I feel compelled to show you this? Well, to disabuse you of the misconception that degenerative changes do not happen in pediatric patients. This is a 16-year-old patient, and the development of degenerative change is not age-dependent, but rather mechanism-driven. And this is something that we really need to understand and keep in the back of our mind as we consider the mechanism of overuse in the pediatric patient population. Well, having said that, let's start with the gymnast wrist. I'm showing you one of the GOATs here, the greatest of all time, Simone Biles, and you can see as she vaults in this case, as you look at this tutorial on how to do a backflip, we understand that these gymnasts, often starting at the age of 2, 3, 4 years old, as soon as they can walk, use the upper extremities similar to how mere mortals such as you and I use our lower extremities, and that's as load-bearing or weight-bearing articulations. Here she's vaulting at high speed, hurling her entire force of the body and weight of the body onto the wrists. Similarly, same sort of mechanism here, although we'll think about how the hands engage the floor as we have these different types of activities. So the chronic physeal stress injury in this case is due to extreme dorsiflexion. You can see that here, and axial loading across the wrist and even into the hand. Over time, this could yield ulnar positive variation. I'll show you an example of what that is in an illustration momentarily. Now, one thing to remember as you look at the mechanism in this case, we see that the wrists are often loaded symmetrically at the same time, so we might expect to see bilateral and symmetric changes. Often we're looking from side to side as a sanity check to see whether or not the changes we encounter are on a symptomatic or asymptomatic side. In the wrist and in the gymnast, we don't have that luxury because the findings, again, are bilateral. And we have to realize that in some cases, these early findings may not be symptomatic in an athlete with a very high pain tolerance. These are taken from an article in the literature, and this article summarizes the spectrum of findings in the gymnast wrist physeal injury. I'll show you several examples of that in a few moments. Neither of these two images show physeal abnormality. Lunate osteochondral defects shown on the left, and you can imagine with the mechanism of injury of loading those wrists, axial load placed across the proximal carpal row, we would stress the lunotriquetral ligament and ultimately have osseous change at that site. In addition, we can have triangular fibrocartilage abnormalities. Again, think about loading that wrist across the triangular fibrocartilage, and I'll show you an example in a few moments of changes in the metacarpal heads. A classic example here of physeal injury with respect to overuse in the gymnast. As you look at the distal radius, look at the radial aspect of the physis. You can see very delicate sclerotic linear margins at the most radial aspect, but as you move towards the ulnar aspect of the distal radius, it's almost as though someone took an eraser and smudged the margins of the physis, resulting in widening. In this particular case, little or no involvement of the ulna, but realize that it can involve both the distal radius and the ulna if we want to understand why we would look very closely at how this athlete loads both of the wrists. As we look at this example, radiograph, MR image here, a gradient acquisition, and a proton density fat suppressed image. The radiographic findings nicely showing us this physeal widening, again, as though someone smudged the margins of the physeal extent. The ulnar physis looks normal in this case. When we move to the MR images, we unmask a finding that was not so apparent on the radiograph, and that's a bone bar or area of premature physeal closure. Of course, when that occurs and the rest of the bone continues to grow grow in the area of open physis, the risk here is that we would have abnormal morphology of the osseous structure. Now, as you look at the proton density fat suppressed image, you can see the altered signal intensity and irregularity at the radial physis, some altered signal at the ulnar physis without irregularity, and look at also the carpal bones where we see patchy altered signal intensity. This often seen in areas of stress change in the bone without fracture line in these cases. Bilateral involvement here, and you can see in this case involvement of both the radius and the ulna. Again, that very smudgy appearance and widening involving both bones bilaterally and symmetrically, something that we would expect in the young gymnast. I said when applicable we would discuss differential considerations, and in this case the differential is for metaphyseal widening or irregularity. If you think about the very basic finding of overuse in the gymnast wrist, that's what we're dealing with, and this is the differential. But you can see, though we have metaphyseal irregularity, the imaging findings are quite different. In the setting of acute rickets, we see this very, very effaced margin. When we look at hypophosphatasia, this looks like geographic areas scooped out of the physis, very different from the gymnast wrist. And in the case of metaphyseal chondrodysplasia or Schmidt dysplasia, we see that the area shows widening of the physis, sclerosis, and chronic appearing remodeling there, which doesn't look at all like that smudged appearance. So while the very basic idea of metaphyseal irregularity or effacement describes each of these four entities, including the gymnast wrist, really the very characteristic and more detailed granular description helps us distinguish between the four as we think about their radiographic appearances. I said that I would show you an example of changes in the metacarpal, and again, as we think about looking at this, finding this case crossing our packs, and thinking about the altered signal intensity that we see here in the metacarpal heads and even the phalanges, we might want to again think about the mechanism of injury and the fact that this person, in doing a backflip, rolls across the metacarpals onto the wrist, and so we can easily imagine why we might have altered signal intensity or stress change, in this case without a linear component or fracture line. Overuse injury in the gymnast wrist and hand can have variable appearances. The corollary, of course, to this type of overuse injury in the adult, first of all, it can lead to ulnar positive orientation. That is to say, having the ulna more than 2 millimeters distal to the radial articular surface. When this occurs, we can see that the ulna contacts the lunotriquetral aspect or ulnar aspect of the proximal carpal row. While adults generally are not, at least routine adults engaged in normal activities, are not loading the wrist likely to the same degree as the gymnast, we can still have repetitive micro trauma, and the findings we're looking for here, of course, don't involve the physis because we have a skeletal mature adult, but we're thinking about impaction of the ulna against the ulnar aspect of the carpal row. A mild case here showing altered signal intensity at the lunate. You can imagine we may also see changes in the lunotriquetral ligament as well as the TFC. Now, a much more severe example with the altered marrow signal intensity, ulnar positive orientation, triangular fibrocartilage tear, and of course, we're seeing associated synovitis. This would be the adult corollary to overuse at the ulnar aspect of the wrist through an impaction or ulnar abutment type syndrome. As we move now to the elbow and the overhead throwing athlete or pitching athlete in the United States for the skeletally immature patients, the little leaguers, shoulder, elbow, both of those things. But as we consider the overhead throwing motion, we can see this with various track and field sports, with water polo, with cricket, several different things. So again, I would ask you to think about the mechanism. With pitching a baseball, we have various different types of action that lead to the overall throwing of that ball. We have the wind-up, we have the late cocking phase, we have acceleration. And when we move into these phases of throwing, you see that what happens at the elbow is significant valgus force. With the valgus force, we have compression at the humeral radial side of the articulation. We have tensile force with opening of the ulnar side of the articulation. And as we repeat this motion of overhead throwing, the olecranon tip engages the fossa over and over again. And so if we think about and dissect the mechanism, tensile stress medially, compression laterally, shear stress posteriorly. And so what will we see? Well, as we consider the very skeletally immature patient, the 10-year-old patient, we look at the ossification center, and that repetitive valgus force can cause fragmentation. We see separation of the ossification center as well as fragmentation. Because we're looking at a growing and maturing skeleton, we have to think about how that's going to change as this patient starts to mature. In this case, you're seeing not so much the separation and fragmentation, but altered signal intensity at that ossification center. And as we consider the 13-year-old, the 14-year-old moving towards the skeletally mature physis closed patient, all of these are going to be your pediatric patients. You see a spectrum of disease. The vulnerable tissue here, the physis, are at the ossification center, altered signal intensity here and slight widening. As you move to the point in time when this physis or ossification center starts to fuse, we see that we have a bit of a mixed situation here where we see subtle altered signal intensity through the bone, and then with complete ossification center incorporation into the distal humerus, it moves towards an adult pattern where the vulnerable tissue now is not a physis or an apophysis, but rather it's the soft tissue structure, the ligament, in this case, the ulnar collateral ligament with partial tearing, high signal intensity within the ligament, as well as superficial to it. So you have to be considerate of, knowledgeable about, and really thinking about where your patient is in this journey from skeletally immature to physis closed situation. So we said at the radial side of this articulation, we're going to encounter the sequela of compression or impaction shown here in the plain film on the CT and on the MR. In this patient with open physis still at the distal radius, we see the osteochondral lesion at the capitellum, very classic. MR helping to assess the bone as well as the cartilage covering. And of course, as we think about osteochondral injuries and lesions, not only do we want to assess the bone, but we want to identify any complications, such as in this case, an intra-articular body. Here we see the absence and remodeling in areas of the subchondral bone. We see irregularity of the overlying cartilage. We see significant altered marrow, signal intensity, all of those really helping us to characterize that osteochondral lesion again in a 17-year-old patient, physis closed, skeletally mature in this case. And as we think about the posterior tissues, in this case, the olecranon, we can see again that similar pattern. Here, as we look at that physis, we see that effaced margin. It's very wide in this area. This is the vulnerable tissue. And we have the stress here again because of the repetitive engagement, the overflexion and extension, flexion and extension through this repetitive overhead throwing. Interestingly, if we compare in this case, in contradistinction to our gymnast wrist, where we have bilateral and symmetric involvement, the overhead thrower is using, of course, the dominant arm. So we see normal closure of a physis on the left side. On the right side, the sequela of this chronic overuse. Another clue that this is the dominant or throwing arm. Look how thick the cortex is in the distal femur. All those helping you to decipher what's happening in this patient. And then when we move to the skeletally mature and adult patient, we start to see that the tissue that's primarily involved is the bone. In this case, altered signal intensity in both the coronoid and the olecranon, subtle linear signal component here. And as we move to the CT, an evolving stress fracture, one of the classic locations in a skeletally mature patient, from the trochlear ridge, that's the junction of the coronoid and olecranon articulating surfaces. I'm sure you're all familiar with the fact that that ridge does not have overlying cartilage and can sometimes be mistaken for a central osteophyte. Classically, that stress fracture can start at the trochlear ridge and propagate through to involve posterior cortex. Another classic stress fracture in the skeletally mature patient, perpendicular to the long axis of the posterior cortex of the olecranon proper. Moving now to the humerus in this little league shoulder or overhead thrower, you're looking at the physis again as the vulnerable tissue as shown here. Often we see that most irregularity and widening occurs at the lateral margin. The more medial aspect often appears more normal. Looking again at a dominant versus non-dominant arm, the dominant throwing arm with that widening and sclerosis, the non-involved and non-dominant arm showing a normal appearing physis. And in this case, that comparison really helps you, perhaps if you're not familiar with this appearance, to be more confident with the diagnosis. As we look on MR, classic finding again, I often find it a little easier to look at the T1 weighted image, although in this case quite obvious because you see the widening and the irregularity. We will often see some periosteal reaction, linear high signal intensity that comes right down the cortical margin. Very classic MR appearance here of that epiphyseal lysis or widening of the physis. And in the case of the shoulder, as we look at the transition to the skeletally mature patient, we move from the physis to labral tissue and rotator cuff pathology. Here we see the labrum detached, contrast extending between labrum and glenoid and into the labral substance, that characteristic of labral pathology. We can see the undersurface of the rotator cuff and assess it to evaluate for cuff tears. Here we see the example I showed you in the beginning of our time together, where we've got labral pathology, we've got full thickness loss of cartilage, osteophyte formation, reactive marrow change, and cyst formation. Moving now to examples of lower extremity avulsive injuries. So we've talked about physeal changes. Now we'll talk about avulsive type injuries. Those can occur at the iliac crest, the anterior superior iliac spine, the anterior inferior iliac spine, the ischial tuberosities as very classic sites. And I will show you examples, the rectus femoris and the ischial tuberosity, before we move to examples around the knee. At the ischial tuberosity initial plain film, when this patient came in with chronic pain in the right buttock and hip region. As you look, the findings on plain film can sometimes be very subtle, but you've got the normal and asymptomatic side on the left to compare to. Very delicate linear here, that area of the hamstring attachment, but when you look on the right side, irregular, fragmented, and separated from the bone. Classic progression of injury in this case, over time, it starts to ossify and can almost look robust and like a separate ossicle or bone on top of the bone, here in the region of the ischial tuberosity. As you look at the ischial tuberosity, there are changes in osseous contour. A simple avulsion involves the infromedial aspect of the ischial tuberosity. A complex avulsion involves both the superolateral and infromedial components. Remember the basic anatomic lesson that changes in osseous contour often reflect changes in soft tissue attachment sites. Superolateral facet, semimembranosus, infromedial facet, the conjoint tendon, that's the biceps femoris, and semitendinosus. Again, look at the plain plain film in a patient presenting with left buttock and hip girdle pain compared to the right side. The remodeling here of that ischial tuberosity, superolateral facet, moving to the MR, hard to appreciate perhaps that osseous remodeling, but here you see the margin of it. Here's your semimembranosus attachment site, and not surprising that this person has pain. Look at all of the altered marrow signal intensity at the site of the abnormality. Ischial tuberosity changes can often be bilateral and symmetric. Look at the changes here. Altered signal intensity, superolateral extending to the infromedial component, high signal intensity both within the bone and superficial. As you look at the left side, the osseous proliferation narrow abnormality as well. Superolateral, semimembranosus, infromedial, conjoined tendon. And remember, when you move forward from that point, you're going to be in the adductor. So you have to be very careful to be certain that you're looking at the hamstring and not the adductor at that ischial tuberosity junction to the adductor tubercle. Moving now to the rectus femoris, this beautiful illustration by Dr. Stadnik from RadSource. He does some amazing illustrations. Here, a sagittal vantage point looking at the direct head rectus femoris. The reflected head extends posterior along the lateral margin of the acetabulum. Here, the tendon and muscle extending distally along the anterior aspect of the articulation. Classic appearance here for an avulsion of the direct head of the rectus femoris. Plain film finding nicely shows that. When you're looking at the MR in isolation without the plain film, you can imagine that this could be sort of confusing. You might say, gosh, there's some sort of tumor. You see the altered marrow signal intensity, the distortion of the bone. Very important to have the plain film or some MR sequence, CT, etc., that you're comfortable with characterizing the bone. There are novel pulse sequences now that are vendor platform offerings that can allow you to have synthetic CT-like appearance of osseous structures, but something that allows you to be confident in this case that the altered signal intensity here and fragment that you're identifying is representing that avulsed rectus femoris attachment site. Of course, mechanism repetitive trauma here with running and jumping in the skeletally immature patient population. Another example here, quite similar, where you're seeing that avulsive physeal injury. That's, of course, the direct head rectus femoris. And this example shows that in our skeletally immature patient population, we can also see adult-type patterns of injury with muscle strain or tear. So don't stop looking once you've seen the expected skeletally immature injury. Keep looking. And of course, the adult corollary here, the hamstring injury, we're not seeing a bone injury, but rather avulsion of the tendon from the emphasis superolateral, semimembranosus, infromedial, conjoined tendon, rectus femoris injury, classically along the muscle and distant from the emphyseal attachment site. And we'll finish up with an example of knee avulsive injury. An important point that extensor overuse often does not occur in isolation, i.e. in this case, you're seeing both an overuse injury at the inferior pulpatella as well as the tibial tuberosity. Syndig Larson Johansson, the classic nomenclature, and Osgood Schlatter for the tibial tuberosity. Take a look here at the tibial tuberosity and then look at the proximal aspect of the tibia here, a relationship, and I'll show you an example of how this pathology can extend into the tibia in just a moment. Again, bilateral involvement is quite common here, seeing the inferior pulpatellar changes on both sides. Look at this example where you see altered signal intensity fragmentation at the tibial tuberosity. Because the physis is continuous with the proximal tibial physis, we can see changes, altered marrow signal intensity, and even fracture that extends up into that tibial epiphysis. Here you're seeing the plain film findings and the sclerosis involving the anterior aspect of the tibial physis. On the plain film, you can see the distortion of the patellar tendon as well focally. So keep those things in mind as you're characterizing and looking for the extent of disease, both on plain film as well as on cross-sectional imaging. And our final set of images today with respect to case presentation, the adult corollary, of course, in the extensor mechanism and with the patellar tendon is the jumper's knee, the vulnerable tissue, the tendon, and now not the bone. Thickening of this tendon, tendinosis underlying, high signal intensity, and partial tearing with discontinuity, partial tearing at the patellar pole, subtle reactive marrow changes, the so-called jumper's knee with a proximal patellar tendon tear in a basketball player. Very classic history. So the take-home points from our time together this morning for you and this evening for me: structural vulnerability dictates the pattern of injury in the pediatric musculoskeletal setting of injury. Structural failure is mechanism driven. OA can and does occur in pediatric patient populations, and common themes include physeal and apophyseal failure. Knowledge of anatomy is really crucial for optimal characterization of disease in these cases. And I want to thank you again so much for the invitation to join you all in your conference this morning.
Thank you, Dr. Chang, Christine, for this exquisite overview of the overuse injuries in the immature skeleton. And as a matter of fact, nowadays, not only the extreme sports athletes, but also several children and young adults get involved with more and more with several sports. So we come across every day with injuries like that. That was very useful. Thank you again. And personally, I thank you a lot for being with us this late hour in San Diego.
It's my pleasure. I only wish I could be with you in person.
Hopefully soon. So are there any questions from the audience? And I encourage the online audience to submit any questions. We have Dr. Isaki here with us.
Thank you. Thank you, Dr. Chang, for this excellent overview of the diagnosis of the overuse injuries. Do you follow up these patients? Do you have a specific protocol per joint, maybe? Do you routinely follow up all of them or just elite athletes? How do you do this?
It depends on each specific injury and the staging of those injuries. As you can imagine, if we start to see areas, for instance, where there's fragmentation of an ossification center, or where we start to see tendon failure, in those specific cases, we may follow up at 8 weeks to 12 weeks. And then, of course, it's guided by the patient's symptomatology. So what we like to see, of course, is that we take away the stress or the overuse component. And as we all know in the pediatric population, and wish that that extended into our adulthood, they heal amazingly well. So if they start to be asymptomatic with withdrawing the overuse, then in those cases, we may not need to have repeat imaging. But if we're worried about or have prognostic indicators that suggest that these lesions may progress, even if they're feeling better, we may image again to be sure they're on the right track again in that 8 to 12 week period. And stressing again, something that Yuria also already mentioned, is that this stress for these kids to really keep performing. So it's really tough for them sometimes to stop. They feel all of this pressure. So I think emotional support as well, to understand that when you release or remove the stress, the healing process almost invariably will occur, but obviously that has to be a complete rest.
Thank you.
Are there any more questions? I have a question. I think it's quite short. I realize that your imaging is mainly based on STIR images and T1 weighted images. Do you use any specific sequences for the cartilage?
Yeah, so for cartilage imaging, generally now we're using high resolution, intermediate weighted, and fat suppressed sequences. And the intermediate weighting is a TE of about 35. With a lot of the image acquisition techniques, we can acquire images faster now. And so we use parallel imaging, we use compressed sensing, but that ends up being the workhorse for articular cartilage. We usually don't use the sub-millimeter volumetrics, and that's just because the contrast is not something that allows us really to identify some of the subtle areas of altered signal that can occur, particularly in the pediatric patient population, that suggest cartilage at risk. So the intermediate weighting, fast spin echo, allows us to assess both the morphology as well as the signal of the cartilage for subtle changes that suggest, perhaps you might refer to it as early chondromalacia, but those biochemical changes, collagen, proteoglycan, that could be reversible in these patient populations if you stop the overuse.
Okay, thank you very much.
Absolutely.
Έχουμε άλλες ερωτήσεις? Are there any more questions? Dr. Chang, thank you very much for this amazing lecture that leaves us with this sense of pride and inspiration of how far a radiologist can go today. Thank you very much again, and a good night in California.
My pleasure. Enjoy your day.
Thank you. Λοιπόν, συνεχίζουμε λοιπόν με την επόμενη συνεδρία, η οποία είναι για το θώρακα.